Okay, good noon everyone. Mabuhay. Sawadee Kap. I'm Dr. Sairi Lagan from the Philippines and I'm here with my co-chair.
I'm Jacqueline Watchmaker from the United States.
So we are here, our session, Next Generation Aesthetic Protocols, what works in combination therapy. And in your clinic, I assume you do a lot of combination treatments, right?
All the time.
It's my favorite because your patients are happy and also your clinic is happy because you do more treatments, right? But anyway, we have a very formidable lineup of doctors here for you, and I hope you enjoyed the session. Please take note, you can ask questions through the app, or you can also ask questions. We have mics here. If the speaker finishes early, we might have some time to have questions in between. If not, we can have questions at the end of the program, all right? So let me introduce the first speaker. So he's a colleague of mine here from Thailand, Dr. Smith Araya School. He will be talking about. Yeah, you're the first one. Yeah, he will be talking about periorbital skin rejuvenation with fractional laser and PRP via microchannel delivery. All right, Dr. Smith?
Thank you so much for your kind introduction. So, talking about combination treatment, when I got this assignment, I really think about what really changed my practice when I do combination this year. So, I going through the periorbital treatment. I think it's something that is super common in every country, right? It's not just about Asian problems. But anyway, this area is quite tricky. Of course, that periorbital skin is something that is quite the thinnest skin in our face. The thickness is only around 400 to 500 microns, right? So usually it's super gentle when we're doing some treatment. It easily to get bruises because it's super hypervasculation, and also it's super easy to get PAH, especially if you have ethnicity like mine. Like in Thailand, we have a lot of PAH problems. So what you really need is that we need energy that can be very controllable in the heat and also with the precision for the safety, because we are working very near to our ocular globe. We don't want to get into that. Of course, that on top of this, periorbital aging is also very complex. It's combining with multiple problems. It's about brown ptosis. It's about dermatochalasis or the skin laxity, including the eyelid descents or blepharoptosis, and also the crow feet. On the other hand, on the lower face, is also another complex problems. It's about sagging of the skin and also the herniation of the infraorbital fat pad. So when we're trying to cope with these multiple problems like this, usually what's come to my mind when I choosing the modalities, maybe fractional laser is quite a solution, right? At the start, I'm same as you. In Thailand, we also start with fractional CO2. And guess what happened? 100% of my case got PIH because there's a lot of heat, right? I learned a lot from it, many lessons learned. So after that, there are the era of Herbem Yak, but you may notice that Herbem Yak having less of the thermal injury. But anyway, it's limited in the efficacy and ends up with a lot of oozing, bleeding, which is quite not pleasant. So what I'm trying to use this time with my combination is something in between with the 2910 nanometer laser, which is a fiber erbium. But what makes it different is really in the details. In this system, it's out clear system that what is the game changer is the frequency. It's got around 5,000 hertz that is more refined in the micropulses, and also the channel that make it into the skin is super tiny, and we can control the diameter. They come into micropulses, an additional of a little pulses between the main pulse that can create the coagulation tissue that can choose the level of it during the thermal relaxation time. I think these details is the game changer. So the reasons why it's really big in sartorial treatment is because it comes with multiple modes of launching the energy, and you may be confusing a little bit about this at first when you are trying to use this kind of machine. Actually, I would like to simplify two modes. It's the more confusing one. The outer one is the small pinpoint that usually we aiming for thermal remodeling with diameter of the beam around 170 microns. On the other hand, there are another mode that is very popular, coring one. Yes, coring is about creating the diameter of the laser beams around 200 to 300 microns. It's quite big enough to get rid of the excess skin. On the other hand, it's not creating scar because it's not reaching 400 microns, which is quite a critical number. So seeing by the histology study, you can see that in the ultra mode or the pinpoint one, it only 170. You can choose the coagulation tissue around it. Usually it's not thicker than 100 microns. And also with the coring mode, you can see that it's bigger in the diameter, around 200 to 300. The average is around 240 something micron, and also including the coagulation tissue around 100 microns around it. So this kind of treatment is aiming for contraction, get rid of excess skin, and also get rid or removal of the fibrotic scarring tissue. So ultra is for thermal remodeling, some rejuvenation effect, making the skin thicker. Coring mode is reset, remodeling, and also excision of the excess skin. So this is the very first clinical picture that I got from the published paper and also from the company that really ignite my idea about periorbital treatment. They use multiple modes. And yes, as I explained before, coring is for the skin laxity, like under the eye and also droopiness on the eyelid. On the other hand, if you're focusing on the skin quality and static lines, you may go to ultra or ultra clear mode, which also can do like a combination to cover all kind of the multiple problems of the periorbital problems. So I adjust my protocols a little bit. In Asian skin, especially my Thailand practice, usually I'm aiming for only ring 1 with depth around 40 to 60 with the drill at around 300 to 500. With the skin laxity, usually the coverage is not high like Caucasian. I stop it at around 2 to 5, not too much of the percent of the coverage with the skin laxity. And more than that, what I would like to combine it, I go back to the basic science of the wound healing process. You have to remember that wound healing process combining with 4 stages: hemostasis, inflammation, proliferation, and remodeling or maturation, right? I think we all, as a derm, we have to remember this. But first, hemostasis is something that we really need platelet. We need the platelet-derived factors like PDGF, TGF-beta, VEGF, right? To making a clot to create temporary ECM scaffold to stop the bleeding. Inflammation is something that we need to gather all the cells and creating the growth factors, going through to the proliferative phase in around first week to around 3 weeks, which related to the summon of the cells of keratinocytes and fibroblasts to creating more of the macromolecules such as the ECM. So at last, it's remodeling that we need the signal to change collagen type 1, to change into collagen type 1 and creating structural change. So what comes to my mind is PRP. Of course, that is containing a lot of the substance, especially is the platelet itself with the platelet-derived factor that can really stop bleeding, right? Remember the erbium, even though it's more refined with some of the micropulses, but we still need something that can help to stop the hemostasis. And on the other phase too, like inflammatory phase, that we don't want too much of inflammation and shifting into more of the organized and repair mode. For proliferation, we need growth factor, and also maturation, we need signal that changing the structure of the ECM that newly growth. So this is my pre and post-op treatment that we do with my erbium fractional treatment around the eye. First, for the free treatment, I will choose the patients who really hydrate their skin. If they come with flaky skin with some acid peeling, I will still postpone the treatment and wait for it for a while because, of course, the target of erbium laser is water, right? And of course, I starting with some of the PAH control with oral tranexamic acid, some topical brightening agent, and avoid the irritation that will cause too much of the inflammation that is unnecessary. On the post-treatment care, I choose PRP. Luckily that in Thailand, we have another system that just launched around last year for activated PRP to make it more better in the growth factor. And it's worth working like this. Actually, it's come in a little box that can creating the environment that make your platelet creating more of the growth factor. Incubate in 4 Celsius for 15 minutes. Thank you for one of my colleagues. She is the researcher, Dr. Jiladami Pansan in CICM. She has done a study about activated PRP that after we incubate it in around 4 Celsius with red light, we can increase exosome for around 8 times. And also, we can increase the growth factor, the IGF-1, that can help with the cell proliferation. So I think she will publish this soon, so I'm really waiting for the results of this. But anyway, with my scientific and skeptical mind, I tried it with my staff for separation with activated and non-activated PRP. And here's the results that we can see together. Okay, on her right side is the PRP and the left side is the activated PRP. What you can see here is that the healing process is much faster in the activated one, especially in day 7. Usually, if we not apply anything or apply normal PRP, the scale will be still remains a little bit in around 1 week. But anyway, with activated one, you cannot see anything at day 7. Usually, the healing process can be reduced for around 3 days, from 7 days to around 3 to 4 days. I think this is really changed my practice in the combination of the treatment. That's why after that, when I do fractional erbium, I really use it combination with activated PRP, especially for the periorbital treatment. And I can promise my patient that it would be around 2 to 4 days for getting rid of all of the redness and also the scales. So I collect some of the case. I have some pilot study for 12 cases with the inclusion criteria of the age around 25 to 45 with the chief complaint of mild to moderate periorbital laxity. And yes, we evaluate with Quantificare 3Ds. You can notice that in 4 weeks, there are lifting in the eyebrows and also the eyelid, which I also collect the distance between the eyebrow and the eye, and also the eyebrows and the hairline. What ends up is that you can notice that the eyebrow is lifting and all of the lines and even the skin laxity is better. So I come to the results. You can see that the average of the lifting effect is around 1 millimeters. The maximum is around 2 to 3 millimeters upward of the lifting of the eyebrow and also the eyelid. And the adverse event is only redness for around 3 to 4 days, comparing to without anything combination is around 7 days and the scale average 4 days. No significant PAH at all in 100% of my pilot study. So for the long-term follow-up, I can really see in 3 months is better. And the longest one, yes, this is the last slide, thank you. You can notice that the rhytids is better and also lifting of the eyebrows. And I have some cases that I also follow up with 1 year already with only one-time treatment. You can notice that the superior sulcus around this area, it still remains better even though it's passing one year. So for my conclusion, you can see that periorbital is something complex. We need controllable heat and also the signaling of the cells that make the inflammation right amount of it and also remaining not too much adverse effect for the long run of the results of the efficacy of the treatment. So thank you so much for your attention.
Thank you. That was very interesting. And our next speaker will be Dr. Smith. Dr. Eliana. Yes.
So yeah,
Yes,
Dr.
sorry,
Elena
Dr. yeah.
Bagnenko. From what country again, Doc? From Russia, yes, yes.
You want to stand on the step first? No. What? No, you want to stand on the step. Yeah. We'll start here. It's good. Oh, it's okay. It's okay. Thank you. Good afternoon, esteemed Presidium. Good afternoon, dear colleagues. My name is Elena Bagnenko. I am a dermatologist, cosmetologist from St. Petersburg, Russian Federation. The topic of my today presentation will be of hand rejuvenation. If we would search the internet and ask ourselves a question, what kind of requests are the most common? We will notice that in course of just 1 month, we have 217 requests for the correction of a dorsal of a hand with fillers out of total almost 2,000. Therefore, it shows the great interest towards this particular procedure and tell us that is recognizable, requested, and popular among our patients. The young skin of dorsal hand characterized with an absence of pigmentation, elastic tissue, and less visualized veins. With an age, the skin becomes thinner, flabbier, tendons become more distinct, veins become more visualized, some amount of wrinkles appear with aging, appear lentigo, bones become misshaped. We have an amazing scale which allows us to determine aging changes of a patient who comes to our clinic. In fact, we can see the development of signs of aging, which fortunately we can successfully correct. And all of those changes we may see in our celebrities. Some of them trying to hit it. Some of them trying I'm so sorry. Some of them are trying to hide, some of them don't pay attention of them, despite the fact that we can see that hands often reveal the age of patient, even though the skin of the face is well taken of. Therefore, it is extremely important to care evenly for both the area of the neck, of the face, and the dorsal of the hand, so that there is not such different, and we have all of capabilities of modern cosmetology for this. This pay attention to the fact that our abilities to correct are connected with restoring the volume of a tissue, camouflaging the veins of a dorsal hand, and enhancing the quality of a skin. How can you receive the aging process after all? We understand perfectly well that age-related changes affect all layers of the skin, and this in particular. The volume of hyaluronic acid decreases naturally. The elasticity of tissue decreases, and quantity and quality of collagen and elastin fibers also decreases. At this stage, we don't simply choose a procedure. We choose a treatment strategy according to the morphotype of hand aging. In atrophic patients, the dominant problem is usually loss of volume with visual veins and tendons. In normatrophic patients, complaints are often mixed. In hypertrophic patients, their main concern is usually skin quality rather than volume loss. So, our treatment plan should be individualized according to morphotype and the dominant clinical problem. Once the assessment is completed, we can choose from several treatment modalities. These include energy-based procedures like picoseconds lasers, IPL, BBL, radiofrequency-based procedure, microfocused ultrasounds, and so on. Injectable methods like methatherapy, biorevitalization, PRP, hyaluronic acid, collagen stimulator like hydroxyapatite calcium, PLLA, and so on. Each modality addressed different components of head aging. So, the final decision depends on the dominant complaint and the morphotype. On this slide, you can see several examples of energy-based methods used for dorsal hand rejuvenation. In first picture, you can see microfocused ultrasounds is used to improve tissue support and skin tightening. In second one, you can see microfocused ultrasounds is used to improve tissue support in skin tightening too. And the third one, you can see IPL therapy mainly directed to dyschromia and even skin tone. On this slide, you can see some of example of injection methods used to hand rejuvenation. Mesotherapy and biorevitalization are mainly aimed at hydration, and supplying the extracellular matrix with supportive components. In the first slide, you can see the injection of hydroxyapatite calcium. I used 1.5 milliliter hydroxyapatite calcium diluted with 1.5 milliliter physician and anesthesia. I used 25 G cannula, and this procedure acts both as a collagen stimulation and as volumizing agent. It helps camouflaging non-collapsing dorsal veins and extensor tendons, which are among the most frequent complaints in our patient. Before and after. As I told you, I performed back of the hand procedures at every appointment, and I see patients 5 days a week. Therefore, I will not hold your attention on this. I would only like to add this simple procedure, greatly enhancing patient compliance. And in conclusions, I would like to say you about combined use these two techniques, ABD with injection, for correction age-related changes is in dorsal of the hand, giving brightly long-lasting result. Thank you for your attention, colleagues.
Thank you, doctor. Thank
you.
you for being on time.
Thank you. Yeah.
But I love it, the hands is something, and as she mentioned, we always forget. So it's an indicator of aging, right?
Definitely. And our next speaker is Dr. Brian Hibbler, all the way from New York City, and he's going to be talking about same-day lasers and injectables, how he does it.
Thank you very much. Thank you to everyone who's here in the audience. We got a great attendance for this session. We'll just pull up my slides real quick. Perfect, thank you. All right, so thank you for that introduction. My name is Brian Hibbler. I'm a dermatologist in New York City. I really appreciated the first two speakers of the session here, and I want to hopefully encourage all of you through my talk to perform combination treatments in your practice, because I think it really delivers the best and most natural result for our patient. And I'll talk to you a few more reasons why and how I do it in my practice. So there's a growing trend towards combination therapy. We know that not one device can treat all of our patients' concerns. And when a patient comes in for their initial cosmetic consultation and they might be concerned about some brown spots on their skin, they're probably also concerned about the fine lines, the skin laxity, uneven complexion, texture to the skin. And we really need a synergistic approach by combining injectables, lasers, and other energy-based devices to address all the layers of the skin. There are a number of other benefits for our patient. We can minimize the number of sessions required, and we can achieve their desired results earlier. But what I want to emphasize here is not every patient needs every treatment. And that's one of the, I think, most exciting and fun parts about my job is when I see a new patient before me and we talk about all the different tools that we have in our toolbox. I think in my mind, where are they going to get the most bang for their buck? What is going to be the treatment that is going to provide the highest patient satisfaction? And then what's the next one after that? And if they've got an unlimited budget, how do we kind of work down that? And how do we package these treatments together to deliver them the best result in the safest way possible? So what's always going through my mind are the different layers of the skin. And I think about the bone, the deep fat, muscle, superficial fat, and the skin. And when it comes to the skin, we think about both the epidermis and the dermis. Once again, we've got a number of different tools in our toolbox, but I only have a short amount of time, so I'm just going to highlight a few things here. My patients in New York City don't want a lot of downtime. They want treatments that are natural. They want things that are safe, convenient for their schedule. And so this is how we're going to combine and mix and match these devices on the same day. Before I go into that, I do want to reiterate, and I tell all of my patients this, that patient safety is the most important thing when we're doing something elective and cosmetic, do no harm. So safety is paramount, and patient satisfaction, to me, is the next most important thing. So don't combine treatments if you or your patient are uncomfortable. If you have an anxious patient, they may wish to start slowly, and they may wish to see the results of each treatment independently. So just kind of keep that in mind as I go through this talk. So here's just some of the different treatments that we're going to highlight real quickly. What I do a lot in my practice is laser rejuvenation of the skin. I think that comprehensive photorejuvenation often requires that we're mixing and matching our devices, because no one single wavelength is going to be able to target all of our principal chromophores in the skin. So when I'm combining laser treatments, I start with targeting the telangiectasias. I want to treat any redness before my other lasers induce background redness. The goal here is intravascular thrombosis and fibrosis of the blood vessel wall. And typically your endpoint is looking for vessel clearance or transient purpura, so a real quick flash when you're hitting that blood vessel. Sometimes we may need to use some purpuric settings for certain types of lesions. Then I use my picosecond laser. I'm starting at a low fluence, and I'm titrating it up until I get superficial epidermal whitening. So many times patients or other providers will ask me, how do I know what settings to use? What are my settings for this particular device? But that depends upon your patient's baseline skin tone, whether it's epidermal or dermal pigmentation, what device you're using. So you always want to know your clinical endpoints. Then I will do my non-ablative fractional laser, and I do a lot of non-ablative fractional rather than ablative lasers in my practice because I treat younger patients. And typically I'll do a combination of 1927 nanometer thulium laser and 1550 nanometer erbium laser. And one of the things that I like to bring up with my patients, when we're doing these treatments and we're doing them earlier, what we call prejuvenation, we're preventing signs of aging by doing an annual non-ablative fractional laser. We have data showing that these laser treatments reduce their future risk of skin cancer. So that's a nice thing to bring up with your patients, that it's not just cosmetic. These treatments are also good for the health of your skin as well. So this is an example of a very young patient of mine. We're just doing something very light. This is 1 month after a non-ablative fractional laser. We didn't combine devices here, but if I am going to combine it, I'll apply topical numbing for an hour beforehand. I usually use either 23/7 lidocaine tetracaine or a 30% lidocaine. I start with my vascular laser, my picosecond laser, and then I will combine both wavelengths of the non-ablative fractional laser, depending upon, are they more concerned about wrinkles and acne scars, or are they more concerned about dyschromia and uneven skin tone? So this is in sequence. We bring them back. We do their vascular laser. We do their picosecond laser. In just a second, you'll see that superficial epidermal whitening in the middle video. So that's my clinical endpoint that we're looking for there. And then immediately we're going and we're doing our non-ablative fractional laser. For patients who are prone to hyperpigmentation, PIH, aggressive cooling. So as soon as I finish my vascular laser, I'm applying ice packs. As soon as I do the picosecond laser, I'm applying ice packs. We have forced chilled air going during the non-ablative fractional laser, and we're following up with ice packs, so that's very important. Now, how do we combine this with injectables at the same visit? Again, I'm starting treatments early, younger patients, but I'm very conservative and judicious with injectables. This is 1.5 cc of a hyaluronic acid filler. We know that not only do you get the lifting from the hyaluronic acid, but every time you do one of these treatments, you're stimulating some of the patient's own endogenous collagen production. And so I like doing smaller treatments spaced out for younger patients, and I will combine it then with lasers and energy-based devices in the same visit. So let's walk through some cases. Here's a patient who's visiting from out of town. They want their neuromodulator treatment, they want botulinum toxin, and they're bothered by some background redness. And the question is, do you feel comfortable using both botulinum toxin and a vascular laser at the same time in this patient? Dr. Watchmaker and I actually did a study where we surveyed members of the American Society for Laser Medicine and Surgery, and we asked them this question. We posed different scenarios. Which devices and injectables do you feel most comfortable combining at the same visit in a patient? And what we found was that most patients were comfortable combining botulinum toxin injections with a vascular or picosecond laser. Interesting, you can see it was only about 2/3 of patients. I kind of thought it would have been a little higher because we were actually surveying some of the leadership of ASLMS. And you can see with combining it with other devices like non-ablative fractional laser, some individuals aren't quite as comfortable with this. When we talk about combining with filler, the majority were comfortable using a vascular laser at the same visit and in the same anatomic region as performing a filler treatment. We also see quite comfort with picosecond lasers and less comfortable with fractional non-ablative lasers. My approach, I'm comfortable doing this. I do my neuromodulator treatment first before I apply the topical numbing. Then I apply the topical numbing. This gives 60 minutes for that neuromodulator to bind to where it needs to be taken up. Then I'll do filler after we take off the numbing, because now they won't feel as much of the injections, but I want to do the fillers before I induce any swelling with my energy-based devices. Then I'll proceed with my vascular picosecond and non-ablative fractional laser in the same visit. So we'll take a look at another example. This is a female in her 40s. She's a former smoker, tanning bed use. She actually has a history of facial skin cancer. She's got atrophic acne scars. She's on low-dose isotretinoin at this time, and she came in just wanting complete rejuvenation of her skin, doesn't want to come back for multiple visits, was comfortable having some downtime. And so first, the botulinum toxin injections were performed, then topical numbing, HA filler, vascular laser, fractional CO2. Had quite a bit of downtime, but had a really nice result in a single visit. So putting that all together, clean the face, do your neuromodulator, put on your topical anesthetic, clean again. Very, very important that you're doing lots and lots of cleaning when you're combining treatments, minimizing risk of infection. Dermal fillers, I will also do ultrasound-based devices at the same visit as well, as long as I'm targeting a different anatomic plane. So if my HA filler is supraperiosteal down on bone and my ultrasound device is going 1.5 millimeters deep in the dermis, I'm comfortable doing those treatments together, doing vascular pigment laser, even cautery or liquid nitrogen, and then fractional ablative and non-ablative lasers. And there are studies showing that patients are more likely to return to clinic when multiple modalities are used rather than just monotherapy. The few things that I do avoid in my practice are fully ablative laser and injectables at the same time, just because if you are truly doing an aggressive fully ablative laser, that requires significant downtime, wound care, risk of infection. So that's a bigger ticket item that I want to make sure everything goes perfectly. And then avoiding doing treatments, energy-based devices, if it's in the same anatomic plane as where I'm placing my HA filler. Then I'll stage it, and I'll do it about 2 to 4 weeks apart. My last case I'm going to present is a darker Fitzpatrick skin phototype with significant atrophic scarring. He wants the best results in the fewest number of sessions. And I present this case because I think, unfortunately, we always tell our darker skin patients that we cannot do lasers in them. And this is a patient where I did a fractional ablative erbium laser to the deepest scars, and immediately in the same session combined it with my non-ablative fractional 1550 nanometer laser. And this was after 2 treatments, and he did not have any issues with post-inflammatory hyperpigmentation. So that's kind of putting it together. If you want to combine with a device because you are worried about PIH, then I'll do microneedling rather than the non-ablative fractional laser. But if a patient's had it before, if you've primed the skin, if you're aggressively cooling, you can do those together. So there are many benefits for the patient, fewer visits. In New York City, patients don't want to take time off of work. They don't want a lot of downtime. They'd rather just come in and get it all done at once. I think it leads to higher patient satisfaction. For you, it leads to more revenue per visit. It's easier to schedule. And most importantly for me, you get to spend more time with the patient during those visits. So I think they perceive a greater value of service, and I really like to spend more time with my patients. So hopefully this encourages you to safely combine treatments to deliver the best result for your patient. But really educate patients during that consultation. That's how you're going to build trust and set expectations accordingly. Thank you.
Thank you. Thank you, Dr. Brian. Those were excellent results. Maybe I will also come to see you. But anyway, for our next speaker, she is a dermatologist from Mumbai, India, Dr. Malavika Kohli. She will be talking about the combination of lasers and injectables.
Oh wow, I've really become tall. One of my wish list for the next time I'm reborn, to be this tall and to see all of you over here and so clearly. So the dynamic duo of blending in lasers and injectables has been really well covered by Dr. Brian and also the previous speakers. So here I am to share my experience. We do know that combining toxin, fillers, and as well as all these different types of energy-based and laser devices leads to treatment synergy, where we're strategically layering multiple procedures to address various skin concerns in a comprehensive and efficient manner. The reason mainly being that a lot of these indications that you see over here are many of them are present in a single patient, and we're looking to treat all of them together for them if we can, because of all the reasons that Dr. Bryan so nicely said. First of all, patients in a hurry. 2, the younger generation wants instant gratification. And 3, social trends also are suggesting that combination is better. And it's not that we have to give in to the pressure of it, but we can intelligently combine treatments. We will definitely have, like you said, fewer sessions, but most importantly, better patient compliance, because then they keep coming for other things as well. It's not such a burden then to do one indication with one therapy, and if you can mix and match, that gives so much more happiness to everyone. So the commonly combined treatments are outlined over here, and I'm going to speak a little more on skin boosters, biostimulators and remodelers, the newer regenerative molecules, and also combining 2 EBDs, such as you can combine HIFU with MNRF or HIFU with monopolar RF, and the 2 of them together give great results. So let's go with toxin. 1 week before or after a laser is ideal, or like was said, I would do the toxin first and then the laser after a cool down period of an hour or 2, or if I'm doing HIFU, then I'll let the skin cool down after HIFU and then do the toxin about 30 minutes later, especially if I'm doing the deeper HIFU at 4.5 or 3 mm. Skin boosters, either I do a first booster to prime the skin. We do know that it helps with hydration, reduces inflammation, stimulates wound repair. So it helps with your laser result as well. In fact, you need fewer sessions. So I may either do a booster. If I have time luxury, patient also doesn't want to do too much at one time, you have that set of patients as well. I would do the laser 3 weeks later, or I would first do the laser or an MNRF or other modalities and then do the booster after that. I prefer to do that, though. Yes, in a way, it's better to do the booster first because it's sterile skin, and then after that, on compromised skin, you prefer not to inject, is preferred. So it just depends on how it works with your patients and you. Newer molecules, like exosomes especially, we are smearing. I do not inject. We smear over the treated area, with whether it's with an EBD or a laser or microneedling RF or microneedling itself. And if I'm doing an EBD, I prefer to do the injectable afterwards, because most of the times in India we have hypertrophic faces and we have to do 4.5 and 3 mm levels. So I'd like to finish that and then use my filler. I do use it in the same anatomic region as well, or in other anatomic regions. Here are some results and cases with skin boosters. We do know that they trigger a major hydration, refreshing effect by stretching the reticular dermis. We know the action is in the ECM, the extracellular matrix. So activation of TNF alpha and growth factors leads to production of procollagen and collagen 1, all of which will help our devices to show much better improvement in skin quality. So here's a young girl, she's atopic, she's finished oral isotretinoin, she has these residual acne scars, and she wants to improve the texture, the right light reflex. She's only 27 over here, and we've used the partially cross-linked 20 milligram per ml NASHA technology in the scars and in the open pores, 1 ml on each side, repeated it 2 months later, and this is her result after 2 months. You could also repeat it 1 month later. She couldn't come, so we've done it 2 months after the second session. So after the second session of skin booster, I then moved on to do fractionated erbium YAG 2940. I prefer that in skin of color to CO2. It just prevents the chance of PIH, and it also, the booster also helps in giving more hydration, better wound repair, get great results, of course, with priming the skin and taking care in between. So barrier function is very important. If you have atopic skins and patients who have barrier dysfunction, repairing the barrier also helps in better results, faster results, and less downtime. You saw the case of subcision being done in a non-distensible star. It's a golden rule to do that. And then we do our energy-based devices like MNRF, fractional skin resurfacing, non-ablative lasers, and then I would end with a skin booster. And there are these papers over here of combining HA injectables for post-acne scars. Here I have used the plasma pro-tip of my Juvena FaceTime machine. But why I'm saying this is because I did something different here. She had already done non-ablative 3 sessions, and she was very dissatisfied. So, and she wanted quick results as usual. She said, I'll do it every week. I said, no, we'll do it earliest is 15 days. So to help also those box and rolling scars that you can see over there, which are the most in the center, the most difficult to treat are those, is that, I'm sorry, I want to go behind. That's the pointer, yeah. Maybe I go behind. Yeah, is that we treated each and every scar with the Plasma Pro Tip, and after that, immediately we used the Hydro Booster, which has got cross-linked HA deliberately because it stays longer and it would give more stretching effect on the fibroblasts. This is her after having done 2 sessions, 1 ml on each side, 3 weeks apart. And then I clicked her 6 weeks later, and you can see the most important thing is that the box scar, rolling scars, and the skin quality all have improved, and with great patient satisfaction. So, happy patient is always, at the end of the day, is what we want. So, improvement in the scars, the sheen, the plumper skin, she herself felt it, and including the light reflex and hydration. So, here's another paper with microneedling alone versus microneedling with HA and post-acne scarrings. Extreme weight loss in this patient. You can see it. Her scars got aggravated, very dehydrated skin, loss of firmness, laxity. So we combined MNRF, waited for an hour, and then we did the skin booster. Again, we used the Hydro Booster with 23 milligram per ml HA. And this was just 1 month later. She was from out of town, so I had to do both on the same day. That's another thing. Brides, patients from out of town, you have to combine. You have to, because they have a shorter time frame within which they give us to work. So this was her 1 month later, and that's her per photograph, but you can distinctly see improvement in volume loss as well as in textural benefits. Another view of the same. And all of these are patients type 4 or 5, and you can see that they're doing really well. Again, another MNRF skin booster, 1 ml of 1 ml on each side. He could only come 2 months later. Each time he came 2 months later, and I would say that in 2 sessions of MNRF alone, you cannot get such benefit in acne scars and depth and volume loss. So that is what I find, that the synergy helps in amplifying the results and doubling the benefits. This is an interesting case. She had done oral isotretinoin, finished it when she was 28. Then she did MNRF 3 sessions, done. She came back 3 years later. She was almost 31 or 32 when she came, and she said, do something for me, doc. I've got terrible scars. You can see the atrophic scars. You can see volume loss. She said, what can you do next for me? So I did an 2940 erbium glass ablative fractionated laser. We did about 4 sessions, after which she said the light reflex improved, but she still wasn't happy. She said, something's missing in my skin. So we used the Nyko technology, hybrid technology of over here, and you can see this beautiful improvement, and you have used 1 ml on each side, 1 month apart, 2 sessions, and this is her after result 1 month later. So bioremodulators, however, I would say that we need to understand that we are causing controlled inflammation over here, and when we're using bioremodelers and stimulators, we have to be a little careful what we're doing out there. We do not want to overstimulate as well. So I find a skin booster right after is a better option. I would leave a gap between a device and maybe a bioremodulator stimulator, just because I want to control the inflammation, get long-lasting benefits. I do not want to hyperstimulate or cause any confusion out there. And here is a lady, we did HIFU, young, lean. She came back 3 weeks later. We did the same Hyco technology, and you can see that she's got the right kind of volume and skin firmness after her HIFU. So here is an interesting case, a nodulocystic acne post hypertrophic scar. This was her clinical and dermoscopic image, and we decided to first do intralesional 2.5 milligram of steroid, followed by botulinum toxin in the periphery of just 4 units, diluted 1:4 to soften the scar, and this was the improvement. That's the dermoscopic image. And then we removed all those milia, and you could see that there is a lot of arborization of the vessels over here, clearly very vascular. So we continued after 3 sessions of IPL, 3 weeks apart. We decided to change and move to IPL, and you can see that she is much better out after the vascular laser, and then we planned to move on to more, and we found then that from doing the vascular laser over here to then adding fractional skin resurfacing with RF, a 10% microablation, you got even better collagen remodeling. This was a before, this was a final after, all in 4 months. Very happy patient, and will give us some time to remodulate, and then we may introduce a booster or a filler to further improve the surface. So also now the use of exosomes over right after smearing over different types of treatments, ablative, non-ablative, definitely helps to improve. Even in one session, a very stubborn resistant melasma, it was resistant to Q-switched. And here is body HIFU. This is 3 ml of the body remodulator, and here we have used 3 ml in the decolletage post-body HIFU, and you can see 1 month later, nice improvement. Then we did the same patient's arms. We did body HIFU followed by 1.5 cc on each arm, and you can see a nice improvement in laxity and texture. So to end, I would like to say that the benefits of a dynamic duo strategy is deep hydration, reducing inflammation, faster healing. You can do it with PRP, you can do it with so many growth factors, not just fancy molecules. These are more reasonable also for the patient. Reduction in pigment and improvement in skin tone complement each other's response for superior results. Thank you.
Thank you. And our last speaker of this session is Dr. Pong Sasitone. Thank you.
Just a reminder, if you have any questions, you can ask the questions through the app. If you're shy to go up on the mic. Yeah.
Good afternoon, everyone. Today, I would like to share my comparative insights on multi-injectable agent for under-eyes rejuvenation. I'm Dr. Sawapak Pongsasithorn. I'm an aesthetic dermatologist from Bangkok, Thailand. Okay, we have to wait for the slide. Okay. Okay, I have been working in aesthetic field for almost 20 years, and for many, many years, under-eyes hollowness correction has been strongly associated with hyaluronic acid filler. However, we increasingly encounter many complications from HA filler. It's because under-eye aging is not a single skin layer problem. The cause of under-eye hollowing include bone resorption, and also fat pad descent and atrophy, and ligamentous laxity, and also the skin thinning. When we get older, the skin at the under eye area, especially the medial part of the under eye area, is almost translucent. It's very, very thin. Then, why are we still looking for one perfect product when under eye aging is a multi-layer problem? This question has driven me to seek for a more effective solution. And that leading me to the concept of hybrid injection for the under eye area. So what are the injectable agents that we can combine to solve this multi-layer problem? Let's begin with HA filler. HA filler still remains one of the most commonly used to treat for the under eye correction. HA filler is the best option for volume deficit. It can support structure. Normally, I will finish the treatment for HA filler in the first session, and I use it as the first step for foundation layer treatment. It can give the immediate result. The limitation of HA filler include it's easily to cause lumpiness. As I mentioned before, the skin in the middle part of the under eyes area is very, very thin. It's so thin that we can see the color of the filler beneath the skin, and which that one is called Tyndall effect. So for the protocol, normally we finish it in one session and make an appointment for 2 to 4 weeks for follow-up, and we can do the touch-up if it's necessary. We use a low G-Pram filler for the area superior to the ORL, and a high G-Pram filler for mid-face volumization and ligament support. The idea Injection plane is deep supraperiosteal plane, and the targeted area include the area lateral to mid-pupillary line and mid-face. We will not inject the medial. We will not inject medial to the mid-pupillary line because we have to prevent the lumpiness and the thin dot effect. Okay, HA filler can last long, about 12 to 18 months or longer. And the pitfall is that using more filler to treat a problem that caused by poor skin quality. When you have poor skin quality, it cannot hold the filler, and then it can cause the lumpiness. Okay. Let's move on to PDLA. PDLA is polymer, it is collagen biostimulator. We inject PDLA in the same session as HA filler. We often inject it after structural correction. PDLA can increase firmness, improve elasticity, can thicken skin at the thin skin, and it provides long-lasting improvement. The limitation of PDLA is that it cannot adequately correct the hollow at the under eyes area. And the result requires several weeks, 4 to 6 weeks to become apparent. Many treatment sessions are required. As you can see at the picture, after 4 months, she still got the hollowing at the under eye. It's not completely gone. This is the limitation of PDLA. All right, for the protocol, I inject 2 to 3 sessions every 4 to 6 weeks. We use small particle size PDLA to prevent the nodular formation. And it is injected into the subdermal plane at the tear top area and area superior to the ORL. PDLA can last 12 to 18 months or longer. And the pitfall of using it in this area is that we inject PDLA too superficial. We inject it too much. And another thing is using the wrong type of PDLA in this area, such as a large particle size formulation. And these two pitfalls can cause nodular formation. Okay, let's move to PLLA, the next one. PLLA is polymer, just like PDLA, they are cousin. PLLA is a polymer that has a stronger, has more powerful collagen biostimulator. When we inject the PDLA, we inject it at the same way. The session sequence, the advantage, also the same. Okay, the limitation also the same, except PLLA has a higher risk of nodular formation. And another thing is that some of my patients report that their under eye hollowness appears more sunken after the treatment. You may look at the picture, the 1 month picture, compare her under eye area with the baseline. She compared that it gets worse. So in my practice currently, we no longer use PLA in this area anymore. Okay, the limitation of PLLA include delay onset of action, a higher risk of nodular. Okay, I already said that. Okay, the protocol almost the same as PDLLA, and I choose micellar PLA formulation, which is a spherical shape. To prevent the nodular formation, it has a lower risk of nodular formation. Okay, I inject almost the same as PDLA, except I will not go in the middle part of the under eye area. Okay, it stays a bit longer than PDLA. And the pitfall I'm gonna focus is that using irregularly shaped microflex PLLA in this area may has a higher risk of nodular formation. That's why I pick the spherical shape one. Okay, another thing is injectable collagen. Injectable collagen is pretty special because it can both provide direct physical volumization and also stimulate collagen synthesis. Okay, I do it after structural correction complete. It can volumize, it can provide volumization result immediately and also can improve the mold quality over time. The limitation of collagen injection is that it has limited volumizing capacity compared to HA filler. It is less potent collagen stimulator compared to polymer-based biostimulator. As you can see in the picture, take a look at the picture 3 months after. You will see that the volume already decreased from immediate after, but not return to the baseline. But her skin texture still get better over time. So, okay, the protocol almost like PLLA. Okay, in Thailand we have 2 types of collagen injection. We have collagen and also RH collagen. I choose RH collagen, which is recombinant human collagen, because it may cause a lower risk of allergic reaction than collagen. Okay, the injection plan is almost like PLLA. Okay, for rejuvenation result, it can remain around 12 to 18 months, but for the volumization effect, I found that it remained only 1 to 3 months. Okay, and the collagen, it is suitable for rejuvenation, not for the volumization. So the pitfall is that using collagen injectable to replace the structure support, it cannot. Okay, then PN or polynucleotide, it can activate fibroblasts, it has anti-inflammatory effect, it can provide tissue remodeling. I will do is the last thing, the final rejuvenation layer treatment. All right, nothing much about PN, but using PN alone is suitable only for the young patient who do not have many skin problems. And the protocol almost like PDLA injection. Okay, PN lasts long around 6 months, and the pitfall is that some patients may not satisfied with the result because they expect the result like filler, but PN can only do the rejuvenation, not the volumization. Okay, biorevitalizer, the last one. Biorevitalizer are the substance that can boost skin health, like skin booster, like mesotherapy, something like that. The product may contain non-costing HA, amino acid, vitamin C that can boost collagen synthesis. It is best for hydration. Its final treatment layer, it can provide hydration, something like that. All right, but the limitation is that it cannot stay long. As you can see, at 1 week, you can see the very obvious result, but after 2 weeks, the obvious result decrease, but not return to the baseline. Okay, the protocol just like PDLA. I recommend to maintain it every month. Okay, so the concept of hybrid injection is like building the house. Is it contained with 3-layer building concept? For the foundation, we use HA filler. For the structure, we use collagen, PDLA, PLA. And for the surface, we use PN and biorevitalizer. Okay, as you can see, the combined therapy, it gives us a better result. Another patient? Okay, in conclusion, my strategy, I would start with HA filler for correct volume deficit for support ligament, and then I will improve skin quality with PDLLA. And I will avoid HA filler in the tear-off area. I will use collagen instead. And collagen suitable for true volume deficiency above the ORL, or for the patient who prefer to avoid the HA filler. And final step, I will go for skin rejuvenation, which is PN and biorevitalizer. Thank you so much.
Doctor, that's actually a very nice strategy. I think a lot of doctors struggle with the under eye, and by combining different products with different layers, then I think it will be better, right? We don't have a lot of time, but we have one question from the app. It's for Dr. Brian. How would you time or sequence it if you have to do HA filler plus HIFU on the same anatomical area in the same visit?
I'd probably start with the HIFU because that's going to take longer to see those results, and that's going to put that bulk heating into the skin. So I would not want to do that right around the same time as the HA filler. So I would probably do that first. What's nice is there's no downtime with that treatment. So do that treatment, and then if you want to stack that and have them come back 2 weeks later or something, then at that point I would do the HA filler.
Okay. Any questions from the floor? Do you have any burning questions? Yes.
Yeah, thank you for the excellent lectures. I just want to ask for the collagen. Of course, if you, let's say, make a mistake in injecting and you get a Tyndall effect or you get lumps, how would you suggest to dissolve it? Because I understand that it doesn't dissolve with hyaluronidase. So how would you correct that? Thank you.
There's no way to solve the collagen. So you better, yeah, maybe flush with the normal saline would be help. Flush, yeah. Flush the collagen with normal saline.
Right away when you get, okay.
Yeah, the only way we can do it.
And so far when I've experienced it, you get a small Tyndall, but it's whitish, so it doesn't bother them too much, and it goes away easily as well. Do you have any?
I was wondering what dose of oral TXA you use before to prevent PIH, and for how long?
Thank you for the question. Actually, for tranexamic acid, usually I prefer to use it around a month before, and the dosage would be around 250 to 500 milligrams per day. But you have to screening the risk factor first, of course. If they are has got a history of cancer or the hypercoagulation stage, and also on the anticoagulant medication. One that really comes to my mind, and one of my friends has got the problem with, is the young women with OCP. This is another risk factor that usually I will shift to be the topical usage. Thank you.
I have a quick question for Dr. Elena. Do you have a favorite injectable for the hand? I know you showed some in the video. And then would you combine two different kinds of injectable?
My favorite combination is hydroxyapatite calcium diluted with physician, 1 by 1. And in one session, I include biorevitalization, maybe methatherapy, before prepare the collagen stimulation, maybe or in one session.
Thank you. Anyone? And then for Dr. Malavika, you meant everyone has asked their question, right? Yeah, but no, you mentioned a lot of HA based for the treatments, especially in scars. Are you using any other like skin boosters aside from HA for the scars?
No, I prefer to use only HA, or I may use PRP with HA.
Yeah. Is it not cross-link? You do also use cross-link for the deep scars?
Yes, for the deeper scars, I'm using partially cross-linked, and also I've used cross-linked. The cross-linked one gives a little better improvement in the plumpness of the skin and a little more long-lasting result as compared to the combined non and cross-linked.
Okay, thank you. Last questions for any of the speaker. When you combine treatments, do you charge them as such, or do you give a little bit of discount because they're combining?
Depends how nice the patient
No
is.
discount? Yeah, depends how nice the patient is. A package? From time to time? Yeah. Me, I'm like Dr. Smith, no discount, but if you're nice, maybe I give a little bit. Anyway, that wraps up the session. Thank you so much. I think we're all hungry, so let's give ourselves a round of applause.